Good morning. We're privileged to be coming to you from the Honor Health Cardiac Catheterization Laboratory in Scottsdale. Our prayers and our thoughts are with our colleagues in the medical profession, nurses, doctors, patient care technicians all over the country during this somewhat difficult time. We have a really great case, and we have a veteran crew. I'll introduce our crew first. We have Garrett, who's our x-ray tech. We have my good friend and sidekick for many years, or actually I'm his sidekick, Kendall. And another veteran of the cath lab, Tracy, is circulating and jumping in as needed. I have my partner in crime, Dr. Burke, who does all of my imaging for me. He does just such a spectacular job. And Dr. Graywall is our anesthesiologist. We have a great case. If we could go to the slide, please. This is an edge-to-edge MitraClip repair in what I consider to be the perfect coapt patient. This patient has severe MR, moderate severity TR, multiple risk factors for cardiovascular disease, and a history of coronary disease. Ejection fraction by multiple modalities is 25%. He's had an ICD placed, he has chronic kidney disease, and he stopped his Eliquis 4 days ago in anticipation of this. He's on that for thromboembolic protection of atrial fibrillation. Could you go to the next slide? The usual cocktail of medications, beta blockers, diuretics, lisinopril, vasodilator therapy, et cetera. He's been on a stable regimen, but still remains fairly symptomatic. Bob Burke, why don't you show us what we have echocardiographically?
Well, from an echo standpoint, again, we have dilated cardiomyopathy. And as we go back from the initial images here, he's got a very large heart, and he clearly has a decreased ejection fraction with here we go. I'll just pull that up. Pretty globular. Sphericity index is elevated. The ejection fraction was again around 20%. He has severe mitral regurgitation, which really seems to be related to A2-P2 malcoaptation. And again, that's more related to dilation of the LV. He is already status post CRT therapy, which really has not helped all that much from the standpoint of improving his functional status, unfortunately. When we actually do the PISA quantification, his PISA mitral regurgitation is severe. As you can see here in our BICOM view, this definitely is A2-P2. There's really nothing that lateralizes, so it's nice central jet.
I think this is a right down the middle. This is a right down the middle type approach with the clip based on that information you're giving me so far.
Absolutely, and our posterior leaflet is nice and long. We had 1.3 centimeters for our P2 leaflet, so that should be a nice setup for an XTR.
Okay.
We have flow reversal within the pulmonary veins, which we're going to use as a target for our therapy, just to make sure that we can see normalization or at least amelioration of the reversal of flow.
Bob, that flow reversal in the pulmonary vein, you and I talk about this all the time. I believe that is one of the primary mechanisms, amelioration of that flow reversal in the pulmonary vein, one of the primary mechanisms for symptomatic improvement. Do you agree with that? Absolutely.
I think that as soon as you decompress the lungs, these people tend to feel much better. And I think that we've shown that our patients who have that normalization of flow feel better very quickly and tend to have a sustained response as far as improvement.
Prior to going live, we did our we obtained our access and then performed our transeptal procedure using an SL1. It was actually TEE guided. You can see I had to work around a little bit of the EP hardware, and so now we're set up for success. I think that's always the important thing with these cases. Make sure you have a good transeptal, good height, that your anterior posterior access through the septum is great. I think we're really in a good position. So Bob, on 3D, you see the position of my ProTrack wire, my Baylis wire. You like that position? That's a good, stable position to have in?
Yeah, this is a good, stable position. It's actually oriented toward the left atrial appendage, but as you can see, it really has no way to go into the appendage, so it just sort of loops around in the os of the left atrial appendage, again, providing safety for us.
That's what I love about this wire. Do we have an ACT? So our ACT is greater than 350. That's a great number, and we try and maintain it in that range during the course of this. You know, there were differences between the MitraFR patients and the COAPT patients. You want to describe why this patient would be ideal based on some of the measurements you've taken for COAPT, and rather than maybe some of the population we saw in MitraFR?
So this patient still has met the criteria for COAPT in that he's on optimal medical therapy with maximally tolerated medication. He comes in with well-controlled hypertension. He's been incredibly stable from that standpoint and has not required any changes to his medications. He's already undergone resynchronization therapy and he's revascularized. So there really isn't anything left for us to do from a medical or interventional standpoint to optimize his care.
So he would fit COAPT. So he would
Yeah.
fit COAPT on that criteria.
So he fits criteria on that criteria, and as it stands, he remains symptomatic.
Now, what about the EROA? A lot of discussion
So
about EROAs between
There's
COAPT
a
and
lot of
FFR.
discussion about that, and actually quantification of mitral regurgitation has really been the mainstay of our approach to mitral regurg in our lab. So we'll use PISA, and granted, there are concerns about it not being a perfect science because, you know, the regurgitation is not a perfect circle. But with that being said, it's still the best quantification that we have by any of our techniques to determine whether or not we have severe mitral regurgitation. In his case, he clearly has severe mitral regurgitation with an ERO greater than 0.4 centimeters squared, and he has a significant regurgitant volume in excess of 60 milliliters per beat. So he meets criteria there, and that's really probably a break point that you can clearly say is a difference between COAPT and MitraFR, where they didn't use the same stringent criteria for mitral regurgitation and having that quantification.
So I think our vetting of this patient, when we first saw this patient, we said, if this were during the COAPT trial, this would be a nice patient to enroll in the trial. Your measurements bear that out.
Yeah, absolutely. And, you know, this is a situation where we've got multiple objective criteria that fit with severe mitral regurgitation, not only the PISA quantification, but also the reversal of flow within the pulmonary veins, and we've seen that on multiple pulmonary veins. We were able to interrogate all 5 pulmonary venous flow, 2 on the left and 3 on the right. We actually did get a signal from the right middle, and we see that there is clearly a target for us to be shooting for in trying to ameliorate that reversal of flow.
So what we're going to do, based on the measurements, we're going to use the XTR system, correct? We have
Correct.
plenty of room for an XTR based on the measurements that you made. And I think, Bob, we're going to try and go right down the center of A2P2 on this.
Yeah, that's going to be the best route to go. I also did a 3D planimetry on the valve, and that showed that we've got a lot of valve area, so we shouldn't be getting into trouble with stenosis. We have an area that's calculated over 6 centimeters squared, so we really should not have a problem from the standpoint of creating a stenotic valve with placement of a clip.
Okay, perfect. So you can see that we're keying the device. It went in perfectly. That's great. You see some saline coming out the tip of the catheter. Come on, Ken, with me. Come on, Ken, hold that. Good.
Yeah, so on echo, we'll see that contrast difference, and really
That's
it's
fine.
as much
We're
a
good.
matter of temperature and viscosity difference as anything else, which gives us a different echo appearance. This is not the same as what we would see with air bubbles.
So I have my clip coming out the tip. I think now, Bob, I'm going to come back just a little bit with my entire device. You agree?
Yep, you got room to move back.
Okay, and what I'm
That's
trying
looking
to...
great.
Okay, great. And what I'm trying to do is get us to straddle. A lot of room to in the
You've
left
got a
atrium.
lot of room.
Yeah.
And I'll switch over to biplane right now just so it's not as confusing for everybody.
So
As
I'm
you can
at
see
straddle.
on 3D, we're great.
Okay, so I'm at straddle right now. You can see the 2 markers on either side of the delivery catheter.
And being at straddle, we'll use biplane imaging on this so that we know exactly where the tip truly is, because in a single plane, it's hard to always know exactly where that tip goes to. It can fall out of plane on our reference or X plane.
So Bob, I'm going to start moving medial
You've-
with my M knob. I've navigated the structures in there I want to avoid.
Oh yeah, you've avoided the limbus, and you've already gone across the opening for the left atrial appendage. We're down below the aortic root, as you can see on the right. I'm going to reset our primary image so I'm a little bit more centered on the mitral valve now, and we'll be able to get a better sense of exactly what your trajectory is. It looks like we're probably going to have to push the system in and optimize there a little bit. Still a little bit high up against the aortic root, as you see on the right. Definitely have room to move. That's looking great.
So we got plenty of height. That's what we wanted to try and achieve. Okay.
Still looking a little bit lateral on this. So I'm going to optimize to where we actually were for our real BICOM, which gets us down into the 40s with our reference or X plane.
Come straight, AP, please. Bob, I'm just testing out my trajectory a little bit. How do you think this looks on TEE?
This is looking great so far. We're really pretty well centralized. We do not have an aorta hugger. As you can see, the trajectory that you've got there on the right plane, the Y plane, is actually looking like we're targeting a little bit toward the posterior leaflet. So this all looks great.
Okay. Now I'm moving a little bit more posterior than I wanted to there. There, that looks better. And what I've tried to do on fluoro is to do my alignment to look at the conformation of my clip arms, but we'll perfect that on 3D. Bob, that looks like, looks pretty good there, doesn't it?
This is looking really good.
That color flow helped
How
me.
much M do you have on?
I'm at about 4 o'clock,
Okay.
about average for where we usually land on the M knob. So the next thing I'm going to do is lift my grippers and clip arm levers, and I'm opening up. I'm not going to open up too much, but just enough. Okay. So Bob, you want to go to 3D and let me see what this the orientation of our clip arms on 3D looks like.
So tilting the aorta down. Looks like we're doing pretty darn well here.
Maybe a little bit of a clock on this one.
And let me just optimize there for
Yeah,
you.
take your time.
Sorry.
Take your time. Just sweeten that up a little bit for me.
Yeah, maybe a little bit clocked.
Not a lot of stored tension. I think right there, Bob.
Yeah, so it looks like we may have a little bit of lateral trajectory
Yeah.
on this when everything is said and done. You've got a reasonable amount of M, so it may pull in a little, but it's nothing like the older version where we would expect a lot more medial dive.
And I'm wanting to get a little bit more. There we go. That's better. You like that better? All right. So what I did was I just, I think I was a little too lateral, and I just pulled back the whole system to get us more medial, and trying to line this up so that our when we cross, our trajectory is just what we want it to be. I think this looks pretty good, Bob, don't you?
Yeah, I think we're looking much better here.
Okay. I'm going to cross here slowly, Bob. I'm going to close up my clip arms just a little bit so there's not too much interaction. I'm not going to dive too deep. I'm just going to try and get below the leaflets. There we go.
All right, you're freed up. Have a little bit of buckling on the posterior leaflet there, but there, now we're good.
I'll just open that up a little bit more so we can avoid some of that. That's nice. So I like my orientation so far, Bob. Do you agree?
Yep, orientation is looking very good.
So I'm just slowly coming back, trying to get the valve to tap on the clip arms. I like my posterior now, Bob. That's getting a little bit of rolling over the posterior leaflet. Go a little more posterior on that and see if that helps my lie. That's better. Posterior looks good, Bob?
Posterior is looking good. Looks like our anterior is sort of tapping and then dropping off intermittently. That looks better.
Got
Posterior
good.
is beautiful.
Yeah.
Swinging around to get the anterior.
I
There
think
we
that
go.
looks pretty
Anterior
good.
looks great.
Going to drop my, you just saw my grippers dropped. Now I'm going to close my clip arm a little bit.
So excellent insertion on the posterior. We got almost all the posterior leaflet there.
So Bob, give me a little look with color before I close down all the way. Oh yeah. Okay, and I'm really still pretty much wide open with it. Let me close down while you're on color and let's see what that does.
So we still have some lateral. Looks like we pretty much isolated everything medially. I'm not seeing any Pisa off on the medial aspect. Still a little bit flow there, though, laterally, as you can see right there.
So I think that's an important point. We don't want to pick a spot where obviously we have flow on either side. We want to try and eliminate the jet on the medial side so that all we have to do is work on one side laterally. So Bob, what we could do is release and maybe try and move under the valve just a tad more lateral. What do you think of that idea?
Yeah, you've got room, and the other part here is when we image, I'm not seeing that you're going to butt up against a cord or anything else like that immediately.
So it's
as
a
I'm
safe,
lateral,
so it's a safe movement laterally
Exactly.
underneath the valve. Okay, so I'm going to lift my grippers, and I'm going to open my clip arms. So it was a fairly, I think a fairly straightforward grasp. So I'm open, still like my orientation. Now, not seeing any cords that might get in the way. I'm just going to push a little bit the system in to get a little bit more lateral on the valve. What do you think about that,
excellent.
Bob? Okay, so now I've lost my posterior, but I expected that. Okay. Okay, that posterior is not cooperating. There we go. Like that a little bit better?
That's looking better. Posterior is completely laid out there. Anterior, a little bit less.
Yeah, give me clear up that anterior for me. That's better. Not liking the anterior. Bob, am I a little too lateral on this?
May have gone just a little too far.
Okay.
Yeah.
Okay. Better?
This is looking better. Now we just have to get that anterior to lay out. Posterior is tapping nicely. It looks like we got both of them tapping pretty nicely right now. Posterior is perfect. Anterior is being a little fussy. Much better. There we go.
Grippers down, closing up a little bit. Now, very important here, one of the important things we do is we give back a little bit, just so we're not putting too much tension on the valve. So after I get my grippers and clip arms in place, so now we've opened up some medial.
Really not anything lateral, but definitely a much bigger medial jet.
So Bob, a little too much medial there, so I'm going to lift my grippers again and open up my clip arms, and I'm going to try and get more into that medial, to make sure we have the medial accounted for. So little too lateral there, don't you agree?
Yeah, that still looks a little too far lateral. I mean, we're really pushing more toward the P1 than we really want it to be.
Okay, so I'm going to try and come more medial here. That posterior is a little fussy. Okay, I got the posterior on. There, not too bad. Posterior's on, anterior's not wanting to cooperate. Bob, what do you think of the anterior now?
Not convinced about anterior right now. There you go. Now it looks like it's tapping. Nope.
What do you think? Can you open up that anterior for me a little bit?
I think we're good. There's it dancing. Okay, so we did catch that.
Nice. I'm going to give back just a little bit. A really important part of this is giving back so we don't closing up a little bit. I think we're back to near where we were on the first grasp, Bob, in terms of how much medial we have. Do you agree with that?
Yeah, we've got trivial medial right there.
What I'm trying to avoid is putting in a clip medial and lateral. So I'm trying to get
Correct.
as much of the medial as I can completely ameliorated, and then we can just focus on another clip laterally if we have to. And I'm not tightened down, Bob. I can tighten down a little bit more.
Yeah. Good. Look at how perfect that is.
So I got good tissue investment. You agree, Bob?
Yep. Yeah. This looks great. So what we've got left on the posterior leaflet, we've got excellent tissue investment there. We've got a wonderful tissue bridge. So that's where you're rolling over, and you can see this right here. You can see how we rolled over with the posterior leaflet. And I don't think you could have gotten much more inside, inside there without being right up against the annulus. So this
Okay.
is superb. You've got about a centimeter just about inside there.
Invested.
So invested.
Okay.
So I don't think we can do much better.
And are you happy with the anterior leaflet, Bob? To me, it looks good, but I'm curious.
Anterior looks good, and we did show that actually bouncing on the gripper, which again is nice to see. As soon as you see the gripper bouncing, you know that the leaflet is there, and you've really gotten hold of it.
Can we look at it as 0 as well?
So again, we can see here at 0 that this looks very solid. And what we're looking for is really immobilization of the anterior and posterior leaflet at the same time. Nice, good tissue bridge there. You can see how that was right inside the clip.
Boy, that's nice. Both of them are immobilized. Good investment on both leaflets.
And you can see on 3D how that really does show a nice tissue bridge across there.
That's a beauty. Bob, you want to give a gradient so we know how much room we have for a second clip? I'm leaning to an XTR, but course, the decision to do another one, another clip, is always based on 3 factors. First factor is, what is our gradient? We do not want to trade mitral regurgitation for mitral stenosis, so Bob will give me a gradient. We want to see at least a 2-grade reduction in the severity of mitral regurgitation. But then finally, we want to look at the pulmonary veins, as we've spoken of, and make sure that the flow reversal in the pulmonary vein has been modified.
So gradient is 2, and that's a little bit generous, so still physiologic.
So if we decided to use a second clip, we have the room to do it.
Absolutely.
Okay, so pulmonary veins. Ooh,
Clearly having some significant improvement there.
wow, that was a beauty.
So these are veins that were completely reversed previously.
So with one clip, Bob, we're talking about a second clip laterally, but with one clip, we've left a physiologic gradient. We've changed the physiology here in terms of the pulmonary veins. And we have about a 2-grade reduction, I think, in the severity of MR.
We do. And, right now this is technically a success, although visually it's still not ideal. We do have room for another clip, which again can help support it. And in this case, we like to try to buttress these valves as much as we can as far as providing a sort of an annuloplasty effect with the bridge. We've got room. We've got room to move with gradient. We had a very large orifice area to begin with. There's really very little downside to adding another clip. Particularly given the fact that we know that there's a reasonably cord-free zone right next to this clip. If we had those anatomic features where there were a lot of cords, we were worried about getting tangled in cords, this was more of a commissural problem, I think we'd have to think very hard about putting another clip in there and try and maneuver underneath the valve.
But we really do have a cord-free zone, as you said. And I think the other point that's important, we're going to be pretty close to the first clip. When we go lateral, we're going to be right on top of that second clip.
Yeah.
And part of that weighs into the decision of whether we'll use a smaller or larger clip. But I think this decision still has not been made until we release this clip. And again, look at your hemodynamics and the severity. Sometimes it gets worse, sometimes it gets better. You don't know until the clip is released. So why don't we go to that phase, okay?
That's our moment of truth.
So we've looked at the images. And they're prepping a second device. I think an NT, my read of the data you've given me is that an NT probably is sufficient. We have an N of, multiple hundred cases, several hundred cases in our lab, and I think we shoot for trivial. This patient has an ejection fraction of 20 or 25%. So I think, in my mind, that we shoot for trivial. I think an NT is probably the better choice. What do you think?
I think that's the best way to go. Again, just dealing with minimizing the chance for device interaction, clip interaction. It's a little bit smaller, less chance of getting into trouble beneath the valve. And since we're going to go in closed and worry about cords, that kind of stuff, even though we're in a cord-free zone, or at least a minimal cord zone, the NT probably has some advantages from the maneuverability standpoint.
And less tension or torque on the
Definitely
on the
less
valve?
torque on the valve, and that potential to twist or placate the valve if we aren't exactly perpendicular to the line of coaptation, probably have some advantage in that regard as well.
Okay, so I think we put an NT in. They're prepping it, so why don't we go to work?
Sounds perfect.
So what you see here, Bob, is showing our leaflet insertion, which looks spectacular to me. And the right-sided view is sort of the owl's eye view, showing really good anterior and posterior leaflet insertion. You agree, Bob?
Oh yeah, this is fabulous. So we've got a great tissue bridge, and actually if you look here in what is our outflow tract view, you can switch it on to 3D and show that you've got a great tissue bridge right there and coming right into the valve. So this is about as good as we could hope for. This is really technically perfect from the standpoint of the XTR.
So what we've done now is we've loaded a second device. The smaller of the devices, the NT device. And you can see what I'm trying to do with my manipulations. I'm trying to do less M knob, medial and lateral movement with the M knob. I want to try and get parallel to the second clip. On your screen, on the fluoro screen, inferior on the screen is medial, superior is lateral. So you can see my clip is aiming more lateral to the first clip. But the important point is less M knob and more movement, in my opinion, medial and lateral by moving the whole system in and out. You get less medial dive. And if I can come parallel to this, I can get this clip right on top of the first one, which is my goal. All right, so what I'm trying to do is get these to run parallel, and I look like I'm doing about what I want to do. Sometimes, I want to show you one thing. So anesthesiologist, while I'm on fluoro, go ahead and hold respirations. Now watch what that does to the clip when you hold respers. It moves it medial. Now do me a favor, do the opposite. Give me 15 centimeters of water. Go ahead and give me 15 centimeters of water while I'm still on fluoro. Go ahead. And that moves it lateral. So you can go back to normal. You can use that to even give further refined movement of the clip. We rarely do that, but okay, so Bob, give me an orientation now. I'm going to open up a little bit.
Okay, go back to our 4D. Your orientation overall is looking much better. I think that we're set up a little bit nicer here. I'll try to clean this up just a tiny bit more.
Okay.
But our trajectory to begin with, I think, is significantly better. Clip arms look great, at least based upon the BICOM and the LVOT.
Yeah, I like that.
And we can drop that down, but you can see where the aortic valve is there. I'll tip that down for everybody.
Yep.
And if anything, we're going to still go a little bit more clock, but I think you're probably going to dive that way. You've had a lot of tension in this system.
Boy, I really have. I think I'm going to wait until we go in.
So this is looking great. I'd say that right now, from the standpoint of our outflow tract view and also from our BICOM, which are our reference planes on the left side, this looks really good.
Good, perfect. All right, here we go. I'm going to close up. I don't like to go through this open. I know some people do. That's not my favorite thing to do. Here we're going through. Now I want to avoid the interaction with the first clip. And we are through. That's nice. Now I'm going to carefully open up, and again avoiding interaction with the first clip, but I'm pretty close there. What do you think,
Opening
Bob?
up nicely.
So could I ask you to give me a far RAO view? Give me a far RAO view. You can play with your fluoro, and you can see that we're not interacting. We're actually separated from that. Okay, here we come. Oh,
Tapping.
nice. I'm going to come right up under this thing. I think right about there, Bob. You
You're
like
tapping beautifully, yep. Look like the arms are dancing there. Definitely inserted well, rolling over on the posterior aspect and on the anterior. And this is looking much better.
I think this
Maybe
is...
some trivial residual right now, and we're not all the way down.
Let me tighten up. And I gave just a tad back. That looks great. I'm pretty happy with that. Bob. I think it
I'm
was
not seeing a lot to really quantify at this stage in the game.
that's what I like to hear. Bob, this is exactly what you and I talked about, is that we were confident we could get this trivial residual, and I think given his clinical presentation, ejection fraction, heart failure, potential non-compliance going forward in the future, non-compliance with some of his pharmacology, I think this was absolutely the right thing to do. And now the gradient is 1.7.
Yep.
Great. You want to just show me pulmonary veins real fast? What pulmonary veins?
That's looking about as normal as we're going to get.
I think this is going to serve him very well in terms of how he's going to feel after this procedure. So what we see is now we had total reversal. And Bob, you want to describe what you're seeing now in terms of the pulmonary vein flow?
So yeah, we started off with reversal of flow, systolic reversal of flow on the pulmonary veins, and as you can see now, we actually have normal systolic flow. There's no reversal of flow whatsoever. We see that on both the right and the left side. There's no suggestion of any residual significant mitral regurgitation. Just based on color alone, there's some trivial leak that's left over, but again, not enough to objectively quantify right now.
I'm pretty happy with this motion for adjournment here. What's our ACT? Okay, let's go into the phase of releasing this. We're going to, again, check our lock line, and I got a good view here. And you can see both those clips moving together really nicely. Okay, and the clip arms, I'm sorry, are not opening, so that's good. The lock is working. Next thing we're going to do is, again, open our the lock on our gripper line. We're going to floss our gripper line. Flosses beautifully. And now the lock line will come out. Now we're ready to release it. And released it is.
Perfect.
That looks great. And look how nicely, Flora said thank you. Look how nicely those are moving together. That is really fantastic. Flora, save that. So Bob, show me one more time what we have. So this is our final. So we have really trivial MR. So we've reduced the amount of MR, almost 4 grades. But certainly we achieved a 3-grade reduction in mitral regurgitation. We have completely changed the physiology of the pulmonary venous flow, and our mean gradient is 1.9. Wow, that's great. That's spectacular. I think by all criteria, this is a very successful procedure. And I think the decision-making in this was first to put an additional clip in, a second clip, and just because of all of the things we discussed, that second clip could be an NT with a high degree of success. Well, it really looks fantastic. So Bob, do me a favor if you would. That's a pretty view. Give me a comparison pre and post.
Okay, so going back to where we started with all this, we had severe, very central mitral regurgitation. And that's what we had started with, along with severe reversal of flow within the pulmonary veins. And at the end here, after placement of 2 clips.
Well, I forgot how bad that looked. Wow, look at that.
And this is what's left over.
Wow.
The mean gradient is only 2 millimeters mercury. And the valve continues to open beautifully. It's well supported down the middle with the 2 clips. And you can see that there's still a little bit of eccentric, laterally based mitral regurg, but again, basically trivial.
That is really terrific. So Bob, why don't I finish doing this figure of 8 here, and then you and I will go over there and make our closing remarks. What do you think?
Sounds perfect.
So as we're giving our closing remarks, I do want to thank 2 individuals that were supporting in the there we go, Milos and Tyler from Abbott Vascular. I think it is extremely important, especially for new programs, even for our program, and we have an N of several hundred, the type of clinical support and education that the Abbott Vascular team provides is irreplaceable. It is really fantastic. And I think if, I want to make some observations. If you're a new operator or a new program just getting started, link up with your clinical team, your clinical support team from Abbott Vascular. They are extraordinarily well trained. They have a lot of knowledge, and I think if you're just starting as a program, getting hooked in with the clinical team there is extremely important. That brings me to my next point. I think the most important aspects of this case, first, was the transeptal. If you get a good transeptal, you have set yourself up for success. You agree?
Oh, absolutely. I think that was the most important thing. And being able to maneuver within the left atrium, particularly with the second clip, was critically important without having to do advanced knobology to buy space to move and then orient the clip appropriately. That was critical.
And that brings me to the second point, and that is the interaction between the imaging expert and the guy spinning catheters. There is no substitute for really, really strong communication between the two operators.
Oh, that's critical. I have to understand what you're doing and when you're going to do it in order to make sure that I give you the right imaging.
Yeah, and I find it impressive that every once in a while you'll say, why don't you move the whole system in, or why don't you give me more M-knob? And I'm like, okay, how do you know that? So that's really an important part of the interaction. But third, and sort of the decision as we were into the case, do we put a second clip in? I think if you're a new team or a new center or a new operator just starting, you may have stopped after the first clip. Technically, there was no flow reversal in the pulmonary vein. We had achieved a 2-grade reduction. That may have been a stopping point. In our program, we use the term technical perfection. We try and leave everything trivial within reason. And so our decision was to put a second clip in, but I think some people may have stopped with the first clip, and I think they would have been justified to do so.
That would be appropriate. And I think for a lot of labs, it's completely appropriate to decrease mitral regurgitation to 1+ or mild and live to fight another day. And specifically, again, with our transeptal, if we didn't have height and we were fighting for height to begin with, I think that going for a second clip may have been a very difficult situation and may have been very frustrating.
Yeah, right. Well, we're delighted to have come to you today from Honor Health. And again, as I said at the beginning, our thoughts and prayers are with each of you, our colleagues across the country during this very difficult time. And we look forward to interacting with you again very soon. Thank you so much.